good morning, good afternoon for those of you not on the West Coast. I'd like to take a moment to introduce our speaker for today's seminar, Dr. Mandy Hill. Dr. Mandy Hill is a professor and director of population health and emergency medicine at UT Health Houston, McGovern Medical School. Dr. Hill brings over 20 years of advocacy and research experience to the sexual health field. Dr. Hill earned her DrPH in disease control at the UT Health Houston School of Public Health. She is established as a dedicated and resilient public health practitioner whose core mission is to improve health by empowering the decision-making capacity of marginalized and minoritized populations with a focus on Black, African American people, and specifically women. Through this central theme, she develops behavioral interventions with innovative and culturally relevant elements. Her research portfolio is currently focused on health communication approaches to interventions that aim to motivate willingness, readiness, and initiation of PrEP to prevent HIV transmission among HIV-naive populations. Dr. Hill, a leader in the HIV prevention field, is working to move the needle on this critical initiative within her community. So welcome, Dr. Hill.
Thank you so much, Dr. Stockman, and thank you everyone for being here today. I am going to share my screen. Can everyone see the introductory slide? Yes, all right. Okay, so my talk today is on tailoring health communication strategies to promote and actualize sexual health for Black women. I do have one disclosure. I am the recipient of an investigator-sponsored research award from Merck Pharmaceuticals. With this study, we did assess perspectives and experiences of cisgender Black women relative to PrEP readiness. The participants were Black women from Houston and Austin, Texas, which are two HIV hotspots here in the state of Texas. So I definitely want to orient everyone to my research mission, which is to center health communication strategies among cisgender Black women in the South. I realize you all are on the West Coast as an important part of our nation's ending the HIV epidemic plan. So I focus on the prevent pillar. As a CFAR, I'm sure you all are aware of the 4 pillars within the Ending the HIV Epidemic Plan, which are to diagnose, treat, prevent, and respond. All of my work is around the prevent pillar. So through this pillar, my work aims to normalize sex as a human action. Sex is something that human beings do. Sex is something that animals do, oftentimes to procreate and oftentimes for pleasure. So also as part of the prevent pillar, we want to educate on what risk or reasons look like in daily life. And we also want to motivate an internal value of personal sexual health. So in addition to preventing, we realize in order to truly prevent and actualize those 3 areas I just talked about, we have to engage the population by promoting a health behavior change among Black women, which will require intervention strategies that align with their normal way of being. So in order to make those alignments, we have to build human connection through social connectedness. We realize oftentimes through my work, this is an avenue that builds trust, because this is authentic. This is something that feels normal, and it feels practical. We want to assess current perceptions of personal sexual behavior. Oftentimes, sex is something that is stigmatized. So we want to address these topics in a way that doesn't include judgment. And we want to build readiness for and openness to new ways of being that include new behaviors to prevent HIV. So as I talked about with that Merck study, We want to build readiness. We want to build willingness to adopt some of these new behaviors that often in my work includes PrEP, pre-exposure prophylaxis. So we talked about prevention, we talked about engagement, and we also want to influence. We want to explain to Black women that influence and/or impact that prevention strategies and behavior change can have in their lives. So here you see a schematic that goes from HIV vulnerability to being protected from HIV. I'm not going to show a lot of statistics because I am presenting to an audience that knows a lot about HIV and prevention and sexual health. So here in the South, Black women are the population of women that are most vulnerable to HIV when compared to other female populations. And when I'm referring to Black women in this presentation, I am referring to cisgender Black women, which are females who identify as women. So knowing that vulnerability of Black women compared to other females, that's the current situation. In order to protect from new HIV incident cases, we have to go through the behavior change paradigm. This will include sustaining an HIV negative status. It will include having more autonomy over decision-making with sexual practices with partners, enhancing confidence with sexual decision-making, and having greater value of one's own sexual health for themselves and for others. I really like that one because that also includes respect, respect for self and respect for others. And so through this behavior change, we can actualize a new behavior and actualize a new normal. And through this new normal, we can protect individuals and networks from acquiring HIV and possibly reduce transmission within sexual and social networks. So I'm pivot from explaining my research mission and the way that I think about things in order to contribute towards preventing HIV to sharing how I got here. So this is a career overview of how I started with my undergraduate studies at the Xavier University of Louisiana. If you have not heard of us, we are one of the best historically Black colleges and universities in the United States of America. I'm matriculated from Xavier after majoring in biology and a minor in chemistry to Tulane. There, I majored in epidemiology and minored in biostatistics. Don't ask me about my biostatistics now. I have a statistician on all of my studies. But I want to share when I started my career of education at Xavier, I wanted to be a doctor. And back then, I thought being a doctor was only a medical doctor. I didn't know about public health. And it was one of my colleagues who talked to me about public health and how you can still contribute towards helping people to actualize better health and better well-being through public health. And you actually can amplify your impact by not only focusing on individuals, but on populations. And I found that very attractive. And so you'll see fidelity towards gaining education in public health through the doctoral program at the UT Health School of Public Health, where I earned my doctorate in disease control, monitoring and health management and policy, and health promotion. And you see, even though health promotion was my minor, most of my work is around health promotion now. And I've been on the faculty here in emergency medicine for 15 years. You can see in my work that I have a fidelity to Black women as my priority population and fidelity to Black populations in general with my work, and have garnered national recognition as a topic expert. And so again, you see this theme of fidelity to the Black community and service, not only as an academician, but generally. So the picture that you see on the left is an award that I received from the Texas Black Women's Health Initiative. This is service. And then you see the Delta Research and Education Foundation. This is also service outside of the scope of my work as an academician. I also have active membership with the HIV Prevention Trials Network, with the Black Caucus, Through my work as an academician, I have been engaged to speak publicly through some media invitations to address medical mistrust with the Black community and as a panelist during the height of the COVID-19 pandemic. And humbly serving as a source of inspiration as one of the 1,000 inspiring Black scientists in America. And so I share that just to kind of show how oftentimes when we have these roles as academicians, it's a theme that we have in our lives as public servants, as advocates, as change agents in our communities, where wanting to help individuals in populations actualize better health, better well-being is something that we do and is evident in everything that we do, not only in our roles as academicians. So taking that back to my short-term research objectives with developing research strategies and capacity to extend sexual health equity to populations who are most vulnerable to communicable diseases and preventable diseases to impede access to sustained sexual health. So these short-term research objectives show up in some of my research foci. So one of those areas is blogging for sexual health. I'm sure many of you are aware of what blogging is, and oftentimes blogs are used to share information in a social way. And so we repurpose that social information sharing strategy, and we're using it as a research tool. And so we're using blogging to promote sexual health. We're also expanding the scope of a clinical visit to include PrEP access in real time by integrating PrEP access as part of the clinical care continuum through any clinical visit with a prescribing healthcare provider. So be it an OB-GYN, an internal medicine doctor, an emergency medicine physician, any provider who has the privilege of prescribing can prescribe PrEP. So how can we integrate this into that clinical visit? And lastly, designing health communication interventions for healthcare providers as our participants to improve access to PrEP with their patients. So oftentimes in research, we go to the vulnerable population who oftentimes deals with the condition, whether it's HIV, whether it's an STI, we focus on that population. However, when we have low PrEP access, it's important to bridge the connection and to focus on those who can prescribe PrEP as well as those who can benefit from PrEP. How do we bridge access from the prescriber to those who can benefit from gaining access? And so a lot of our work now is focused on that. So I'm going to share some of the work that I have done in this vein, starting with the way that we pilot tested behavior interventions through randomized controlled trials. We engaged community members through clinical settings. The first study leveraging the emergency department to engage Black women in HIV PrEP. This was the iPrEP study where we repurposed a survey, and this was actually the HBTN, which is the HIV Prevention Trials Network's 073 study. It was their survey that they used with Black men who have sex with men to assess PrEP adherence. And we were allowed to use that survey. We used an adaptation matrix and operationalize that survey almost as an intervention. And we enhanced it with motivational messages to raise awareness of personal behaviors that may increase vulnerability to HIV. And we also tailored it to cisgender Black women when the original focus was on Black men who have sex with men. And some of those motivational messages were around condomless sex, substance use behaviors, substance use during sex. The intervention also increased knowledge relative to PrEP protocols, health benefits, and side effects. And so the women who took the survey, they felt that they were just taking a survey. They didn't realize that they were receiving education or possibly reading scenarios that could increase their motivation for PrEP or increase their willingness to take PrEP. And so this is the overview of the process for the research, where the patient population were engaged through the emergency department. We screened them We approached them if they met the inclusion criteria. We did a pre-screening. If they met the pre-screening criteria, we did consent. For those who consented, we randomized them using REDCap to either the intervention arm, which was the iPrep intervention, or usual care, which meant they went through the normal process of ED care. We did a one-to-one randomization where there were 20 individuals in each arm, which was our original sample size. After they were randomized, they did a pre-test, they completed the intervention, we did a post-test, and then they were referred to a prep clinic. We refer to this process as a warm handoff because the coordinator walked them through the entire process of scheduling transportation to the prep clinic within 72 hours. They received a gift card. They were able to make an informed decision about the prep clinic that they chose. With some highlights, some of the prep clinics offered women's care services or housing access, different types of resources that may have met the needs of the women. And over a follow-up period of 6 months, we assessed outcomes, which were an increase in prep clinic visits or an increase in prep uptake. And so there were two prep clinics, Allies and Hope and Legacy Community Health Center. We were only able to link officially one person to PrEP, and that person did stay on PrEP for 30 days. This did occur during the COVID-19 pandemic, which did create some barriers to PrEP uptake for cisgender Black women. We did learn throughout our 3 assessments over the 6-month follow-up period, which were at 1, 3, and 6 months, that the risk of contracting HIV didn't seem to be a big priority for our patient population. There was misinformation about PrEP eligibility and appropriateness for women, which we found to be secondary to some of the media messaging. And this continues to be a theme 3 years later with our qualitative work. There were some concerns about PrEP safety and having a trusted PrEP information source, as well as stigma about accessing HIV prevention services. Findings of this study can be found in the Contemporary Clinical Trials Communications Journal, as well as BMC Infectious Disease. And we did garner some national attention from this study through the New York Public Library, as well as through URIC Alert in Washington, D.C., through AAAS. Anytime I present, I do like to acknowledge my team. So on the left, you see Dr. Haynes. This is my former doctoral student. She completed her dissertation based on this study. One of her studies is published in AIDS and Behavior, and she has a few more that she's working on. Our master's student completed her thesis based on the findings of this study as well. And then you see the rest of our team. So you will also see here, it's important when we do research to also further the education and the development of our students and create opportunities. So now we'll move to blogging for sexual health, where we engage cisgender Black women in HIV prevention research using a culturally relevant health communication approach. So this is where we conceptualize blogging for sexual health. The young lady in the red is Dr. Sandra Coker, who is now assistant professor in my department here. But in 2019, Dr. Coker was a medical student here at McGovern Medical School, and she is an expert blogger. And so we co-created this ideology of using blogging, which she had expertise in, with my expertise as an HIV prevention researcher, sexual health researcher, to use blogging for sexual health. And so we piloted that idea with this study, Debunking Myths. So we compared 2 strategies, and we assessed which strategy would be better at dispelling myths on how HIV and STIs are transmitted in Black and African American communities. And the purpose here is because some of these myths are really believed to be true because they've been told from generation to generation. For instance, you can get an STI by sitting on a dirty toilet seat. This is something that has been said over and over again. And even though it isn't fact-based, the fact that it has been repeated so many times from generation to generation, it is believed to be true. And we wanted to know if by storytelling or using the taboo method, if we could dispel some of those myths. So with storytelling, there are two young ladies here having a conversation, sharing stories, and one person shares this story and shares misinformation, and the other person corrects them. We wanted to see if that correction was effective at challenging misinformation. And with the taboo method, it's one person giving a monologue. So Dr. Coker is giving a monologue, sharing information. And when she says something incorrectly, she appears to the right with her white coat and stethoscope to correct herself, even though, she's supposed to be someone else. But by correcting herself with a white coat and the stethoscope, this represents the provider recommendation, which we know to be very influential with the decision-making of Black women in the literature. So we wanted to test if the provider recommendation would be effective at dispelling the myths. So that was the aim of the study, to assess which one was stronger. This was our inclusion criteria: cisgender Black women who did report being sexually active within the last 3 months. They were between 18 and 40 years of age, and that this did take place in the emergency department with women with non-emergent conditions. And what we mean by that, these are individuals who have low acuity, meaning it's not really serious. This is not someone who has sepsis or someone who's had a car accident or has a life-threatening situation. This is someone with a common cold or something that is not deemed emergent. Okay, so the process was similar to the IPREP study, where we assessed inclusion, exclusion criteria. We did a pre-test. They were randomized. They did the intervention, did a post-test. The entire study process took about 20 minutes, so we were very impressed with that. They were randomized 1-to-1, 13 in each group, a total of 26. We were able to present these findings nationally, and we published the findings in the Western Journal of Emergency Medicine. Now, the study did not provide the results that we expected. Neither strategy was very effective at dispelling myths on how HIV and STIs were transmitted. The knowledge was kind of the same between pre and post test. However, the women really engaged very well with the tablet device and were having full-on conversations with the tablet device. So we realized we're onto something with this strategy. So we decided to repurpose it. And so we disseminated the behavioral research to the population by engaging community members through social media. So you'll recognize Dr. Coco with the same red shirt, same hairstyle, because we spliced those vlogs, which were 10 to 11 minutes long, and we created snippets that were around 30 seconds. And we shared those snippets, and we just took the snippets that were about preventing HIV and STIs, especially those that talked about PrEP, and we ran a 6-month social media campaign, and we used an algorithm that identified females that were aged 18 to 55 years old, and we focused on those who resided in zip codes that are predominantly Black and African American residents in the Houston-Harris County area. And the reason why we use zip codes is because when we submitted this proposal to the Texas Development CFAR, race was a variable that you could use in an algorithm. But by the time it was funded, race was no longer an option. So we use zip codes as a proxy for race. And so we were able to disseminate these findings through national conferences, through some local forums. We won a few awards. We really had pretty broad reach. We had over 1 million impressions with these vlogs on social media, which let us know people will watch this on social media. We have a manuscript that's under review right now with the Journal of Medical Internet Research. So we are hoping to have this publication and this contribution to the literature very soon. And this is our team. We could not do this without our Facebook ads expert, Mr. Tristan Sutton. And it's really cool how we've been able to use blogging, use that skill to advance sexual health research. Okay, this is my final study, but this does not mean that I'm close to the end. Just want you to know. Okay, so this final study, we have a strategic plan to develop a woman-centered, culturally relevant intervention to increase PrEP uptake among Black women in Houston, Texas. So this study was through the UJIMA pilot study, and this is through the UJIMA Scholars Program where I met your illustrious Dr. Stockman. She was my ARC mentor. And this is through the UCSF CAPS program. You may be familiar with their Visiting Professors program. So the UJIMA mentoring program was created to support researchers who focus on Black populations for the treatment, care, and prevention of HIV in Black populations. So as part of the program, we received funding for a pilot study. And these are the three aims of the pilot study that I initiated and completed with the support of Dr. Stockman and Dr. Santamaria. So with aim one, we examined patient-provider health communication among Black women and healthcare providers of Black women regarding awareness of and access to PrEP. So you heard me speak about this earlier, why it's important to bridge that connection. Well, this study allowed us to explore the importance of bridging that connection. So we examined those the patient-provider health communication, the perspectives of both the providers and Black women, which informed the health communication material that we developed in AIM 2. From those perspectives, that informed the content for our video logs in AIM 2, which aim to enhance access to PrEP through the lens of the provider and the patient. So we created a vlog for providers and a separate vlog for the patient. In AIM 3, we pilot tested those vlogs in the emergency department, and we evaluated whether vlog viewership translated to behavior change in both populations, specifically linking women to a PrEP clinic. So if the woman watched the vlog, did this motivate her to attend a PrEP clinic visit? And if the provider watched the vlog, did it motivate them to refer a Black woman to PrEP or write a prescription for a Black woman to take PrEP? So with AIM 1, we conducted 12 one-on-one interviews with healthcare providers, and we conducted 7 focus groups with 20 cisgender Black women. We presented those findings nationally and internationally as 7 abstracts. The preliminary findings did inform an R34 grant that was funded and a fall 2024 R01 submission that's currently under review. We do have 1 manuscript that has been published in the International Journal of Environmental Research and Public Health. I will have a QR code for you coming up. And we have another paper that's focusing on the interview findings from those healthcare providers that's in progress. These are some descriptive data of community members who completed the screening for cisgender Black women. And you'll see here, I am showing the survey respondents. There were 241 survey respondents and 20 participants. So we had quite a bit of responses from our survey for screening. And you'll see the biggest difference here is that of our survey respondents, most of them were 18 to 29 years of age. However, our participants were quite a bit older, where most of them were 40 to 49 years of age. So here we have a snapshot of some of the themes and codes for cisgender Black women. So we organized our themes by locus of control. I'm not sure if many of you are familiar with that, but locus of control is a psychological term that describes the way that you pretty much see life or interface with life. So those with an external locus of control, life kind of happens to you. Your external life governs your lived experience. So I will use an example. If you go to work and someone says something negative to you, that could make you have a bad day because that external person dictated your daily experience versus someone with an internal locus of control, who you are on the inside governs your external lived experience. So same scenario, you go to work and someone says something negative to you. Yeah, that person doesn't have the power to dictate your lived experience. That person just said something negative to you. It's probably something negative with that person. And you can move on and have a great day. So we use the external locus of control to organize our codes and our themes. So we had 6 external locus of controls and 11 internal locus of control. So for example, media influences was a negative, was an external locus of control. So you'll see in the past, I showed a slide where Black women felt that PrEP wasn't for them based on what they saw on commercials or from the media. So based on what they saw, that made them make an internal decision that PrEP was not for them. That was an external locus of control versus an internal locus of control, PrEP knowledge, PrEP awareness, and self-advocacy. I would even say self-efficacy would be an internal locus of control. So that allowed us to organize our themes and codes for cisgender Black women. And here's the QR code that I mentioned. And I can come back to this if need be during our Q&A. So here's a snapshot of some of the themes from our healthcare provider interviews, those 12 interviews that I mentioned. We had 28 themes overall, and I'm highlighting here the themes that were used most frequently. Providers experience discussing sexual health. They described that. The provider's approach to patient engagement, the provider's knowledge of PrEP, the provider's approach to determining PrEP eligibility, and the provider's comfort with engaging patients about PrEP. Under the theme of patient engagement, several participants, which we know are providers, highlighted that their approach to HIV prevention discussions were directed towards sharing the importance of refraining from making the patient feel judged. And I thought this was important to highlight, especially with how common provider discomfort in initiating or having sexual health discussions is mentioned in the literature. So choosing not to have the discussion because you're concerned that the patient may feel judged could be birthed out of a few different reasons, right? Is it an internal judgment that the provider truly has, or apprehension that brokering the conversation and not having comfort or skill around managing sexual health discussions and fear of doing it incorrectly could go wrong? All of those reasons would mean that there needs to be some education and skill building for providers and having more comfort and confidence around having those conversations with patients. With AIM 2, with developing the vlogs, we engaged a research coordinator and practicum students who posted e-flyers on social media. We had a blog director as well, who posted e-flyers in 4 acting groups. And so we assessed the feasibility with community-facing auditions. And here you see some of the outcomes of that. We had some no-shows. We had some who didn't make a selection. We had some who scheduled and were no-shows after rescheduling. So it was a bit of a challenge, but we made it through. And here are the recruitment flyers that we used. On the left, this is the flyer that we used for the vlogs with Black women. And on the right, these are the vlogs that we used for healthcare providers. Not the blogs, the recruitment flyer that we used for the vlogs with healthcare providers. So from the auditions, we made selections with a team of 4. This included the vlog director, myself, coordinator, and practicum students. And we notified actors via emails. We used written templates that we tailored with names and personalized them for each actor. The vlogs were filmed on the same day at 2 separate locations. They were revised and edited by the videographer with input from our research team and our investigators. And then the final vlogs are made available for pilot testing in AIM 3, which we facilitated in July and August of, is it this year? Yeah, this year. Okay, so I'm going to share some of the details with our development process. So here you actually see blog development in progress. We did this in a beauty salon. We created the vlog script as a team, and we decided that the conversation should take place between a hairstylist and a client. And oftentimes, this is a place of trust and openness. So we thought that this would be a real life type of scenario that a lot of Black women could connect with. And it was the blog director who had the relationships with a real salon owner that would allow us to film in that setting. And she did a wonderful job at creating an inclusive environment. You can see just from her body language with her having a conversation with the actors, fostering authentic synergy. And they had fun and they were engaging. You can see laughter in the second picture. You can see her touching them. For several of them, they were meeting for the first time, but she created an environment that really translated on screen with the vlog for a really comfortable feel. And some of the other considerations with environment, the salon owner used her own wigs, as you can see here, to put on the wall to also create a real live beauty salon feel to enhance the environment. And we had practice sessions on set. And so you see them back here. She's facilitating them practicing their lines. This is the client. She's looking in the mirror, practicing her lines. The client was a real actor. This is someone who's recruited from those acting groups. The person acting as the hairstylist was a real life hairstylist who did not have acting experience, who had a lot of confidence in learning her lines and who felt she knew her lines. And on set, out of nervousness, she could not remember her lines. So it was actually the hairstylist who decided we would clip the lines in her hair after several takes and running out of time because we had a second vlog to film, to just clip the lines in her hair so that we could progress and complete the mission, and it worked. So being prepared to pivot in real time was actually really, really important for the development of that vlog. So we're going to move on to the development process for the vlogs for healthcare providers, where we actually filmed in a real clinic setting. Our community partners at Allies and Hope directed all of their patients to their second clinic site for us so that we could film in their setting. So again, relationships and how important those are. It being really important to film in an authentic healthcare setting for background, for providers, for it to feel real, and maintaining fidelity to that clinical care cascade. You see, we had someone who was in a extra role acting as the receptionist. And we have our provider practicing her lines in a room on her own, independent, great professional. And this was the provider and this was the client. They knew their lines. This filming process took less than an hour. The first one, when they were less prepared, took almost 4 hours. So that varies. And this is our videographer here. And so it was an added bonus because not only were we in a clinical setting, we were in a clinical setting where they did sexual health on a regular basis. So the environment, you see Biktarvy, you see Apretude, intimacy in your health. Let's discuss Descovy. You see the comparison of Descovy and Truvada. You see this is a safe place to be who you are. All of these visuals contributed towards the environment feeling real and natural. And actually, our provider was able to pull this Apretude pamphlet and use it in the vlog and hand it to the client in the vlog. So we saw that as a benefit too. I don't think we really considered that prior to. So with AIM 3, we had a third practicum student. So again, engaging our students. She was a trained pharmacist and she engaged in the recruitment and room enrollment and follow-up calls of both cohorts in AIM 3. We did meet our accrual goal of 20 participants, 10 cisgender Black women, 10 healthcare providers. We had 30-day follow-up calls. We did have some loss to follow-up, which we didn't like, but it happens. We had 6 out of 10 cisgender Black women complete follow-up, 4 lost to follow-up, and 8 out of 10 healthcare providers complete follow-up, 2 lost to follow-up. So with our primary outcomes for cisgender Black women, of all participants, 4 reported speaking to friends and or family about PrEP to get their thoughts on it between the baseline and 30-day follow-up. 1 participant did some research about PrEP to see if it was something that she would consider, and only 1 participant reported that they had done nothing since viewing the blog. And here are some of the qualitative quotes from cisgender Black women who perceived barriers to PrEP. The first one, and I'm not going to read that one, but with that one, I realized that the participant didn't fully understand that PrEP was for HIV prevention. Her conversation with friends was directed towards friends that were HIV positive. So that created an opportunity for re-education. We had 1 participant who didn't perceive any barriers for getting access to PrEP 30 days after. And then we had some others who just weren't really thinking about it, felt that everything had been good so far. And even though they understood what PrEP was, still didn't really see it as an immediate interest or option for them. So with healthcare providers, of all the participants that we engaged, only 1 provider reported referring 2 cisgender Black female participants for PrEP. So I want to clarify there. The 1 provider who reported referring 2 cisgender Black female participants was the only provider who reported referring or prescribing PrEP to any Black female participants. And so here we see some of the perceived barriers to PrEP among providers. And I found this to be very valuable from the study. One of the themes was that providers discuss perceptions about the patient population. 1 provider said, I haven't seen that patient population in the emergency department. Another provider talked about most of the people that I saw probably did not have that concern. So we see these assumptions that the people I'm serving may not be at risk. This provider also said, I usually see plenty of people are usually worried about that kind of thing. So we see these broad generalizations that doesn't really serve CDC recommendations, which is that PrEP is for anyone who asks for it. Another theme was provider responsibility to lead sexual health discussions. 1 provider stated, I think it is the approach of the provider in thinking of the opportunities to talk to them about it. Otherwise, it should be a conversation. Another provider stated, I also initiated the conversation with a woman who said she wasn't ready, but I did start the conversation with her and let her know it was something that was available and something she could use for her overall health. So I found that to be encouraging, the willingness of the provider to have the conversation with the patient. Another theme was perception of scope of practice. This provider stated, I mean, for the most part, I'm usually prescribing PEP, post-exposure prophylaxis, which is unfortunate because who we are seeing in the ER are people who are being assaulted, even after the video. This is not something I'm regularly thinking about unless there was an STI, which would still be PEP. I don't know. So we see, and I'm seeing this outside of the study, just in general, conversations about PrEP. It isn't seen as more of a preventative option. It's more of a treatment, like this person is saying, after an exposure or after an STI. I more see sexually transmitted infections as a treatment and care option, not necessarily preventative. So we definitely have some work to do there. And lastly, with knowledge, a provider stated, usually we don't get too much into understanding how the prescription works, which ties in to the perception of scope of practice. So this is just some demographic information of cisgender Black female patients in the emergency department. We found them to be mostly young, 18 to 29 years, Black, heterosexual, highly educated, 40% with graduate professional school. We see variance in income, and then most of them with public Medicaid or Medicare insurance, 40%, but then you see 30% with private. So there's a mix there with insurance status. And then when we look at cisgender Black female patients, it's the same in the emergency department. When we look at some of these behaviors, we see oftentimes there is a current sexual partner. Most times that current sexual partner is the main partner. We also see most times they have not heard of PrEP. And then even in not having heard of PrEP, there's still a perception that anyone can access PrEP. So we found that to be interesting. When we look at the demographics of healthcare providers enrolled in AIM-3, most were female, 90%, cisgender women, young, 18 to 30 years of age, non-Hispanic, English-speaking physicians, most in emergency medicine, which makes sense. We recruited from the emergency room, and with 1 to 5 years of practice. So residents were more willing to participate in our study. So our takeaways are that when designing interventions, we should always involve the voices of the people that the intervention aims to engage. And we try our best to make those options available. You see, with our research, we try to start qualitatively to make sure that the voices of the participants informs our intervention approaches. And as I stated with the individual who didn't remember her lines, we want to be prepared to pivot and problem solve. We can't let problems stop the research. We have to be willing to pivot. And behavior change is always an ever-moving target. So our success as interventionists is in motivating movement towards healthier behavior. And with the Ujima study, we want to acknowledge our team. You see your very own Dr. Stockman there. And our community partners, we couldn't do it without them. And so we want to expand blogging for sexual health to expand the potential of this approach for public health impact. We want to contribute towards the national ending the HIV epidemic plan through prevention goals as stated before. And we hope that we can build something sustainable to extend our proposal outcomes to inform new and similar interventions that can scale up the rigor of this design to reach a broader audience in Texas, the South, and beyond. And so I mentioned the R34 before, but I didn't show you or explain how the research builds on one another. I talked about the Ujima pilot study, and I mentioned how we used the Debunking Myths study, and we repurposed it as the social media campaign, which was funded through the Texas Development CFAR. The Ujima pilot study and that Texas Development CFAR study, those pilot studies informed our R34. So you see this progression of our research where we continue to build and use the pilot studies to further the research mission. And that ends my presentation. Any questions?
Thank you so much, Dr. Hill. This has been an amazing talk. It's been nice to see your career trajectory and how that has fed into your research and just how your research has evolved and the innovative way in which you've used health communication and in many different ways to advance HIV prevention efforts among Black cisgender women. So congratulations and thank you so much.